We walk you through the Dutch health system using the Duplex framework. First, from a demographic view, the Netherlands is aging quickly, but 1 in 5 people are now over 65 years old. Next, most health issues come from long-term disease, and many adults, especially older and lower-income groups, have more than one condition. Then, the political and legal system is built on mandatory health insurance and a national benefits package. It supports fairness, but the rules and the process can be slow and complex. On the economic side, the country spends heavily on healthcare and elderly care, but aging, rising costs, and staff shortages are creating serious financial and workforce pressure. Socially and culturally, people value independence and digital access to their care. And ecologically, because the country is low-lying, climate risks like flooding and heat waves are real concerns for the health systems. And in terms in technology, the Netherlands has strong digital tools, yet gaps in data sharing and digital skill limit how much the system can be benefit from them. Now, looking at the impact map, the biggest and most long-lasting pressure comes from aging and climate risk. Over the next 10 years, workforce shortages and long-term care costs will also have a major impact, and medium-level factors like digital gaps, social inequalities, and regulatory complexity still play an important role in how well the system adapts.
The Dutch health system pursues care goals such as delivering effective, safe, and patient-centered care, ensuring equal access for everyone, and keeping care affordable and financially sustainable. These goals are supported by compulsory insurance for all residents, community-rated premiums, regulated competition among insurance, and clear decision about what care is publicly covered. There's a current national policy set out in the Integral Care Agreement. The IZA emphasizes appropriate care, providing the right care in the right place at the right time, which means shifting more service towards primary, home, and digital care, cutting low-value treatments, strengthening prevention, improving regional cooperation, digitalization of health information, and tackling workforce shortages and making healthcare more environmentally sustainable. Now, performance-wise, when we look at the table, the Netherlands performs strongly across international health indicators with high life expectancy, low avoidable mortality, and very low infant mortality. Now we look at the effectiveness and efficiency. Spending level around 10% of GDP, which is moderate for a system that includes extensive long-term care and cost control measure to help keep spending growth manageable as the population ages. Financial fairness is a major strength. Coverage is almost at 99% out-of-pocket payments are very low, and people are well protected from financial risk. The system is also highly responsive. Unmet medical needs are among the lowest in Europe. Waiting times are relatively short, and patients can freely choose providers within a strong primary care gatekeeping model. Patient satisfaction is consistently high, with the Netherlands repeatedly ranked first in the Euro Health Consumer Index and scored well in OECD surveys. Equity is firmly embedded. Contributions are income-based, and government supports for those who have lower incomes, and everyone receives the same basic benefit package nationwide.
Now, I will briefly introduce how the Dutch healthcare system is organized and how money cash flows through it. The Netherlands use a managed capitation model, but with strong government oversight, citizens are required to buy basic health insurance, paying premiums to private non-profit insurers. These insurers then contract to hospitals and other providers, creating three linked markets: insurance, purchasing, and the provision. Even with capitation, the state still plays a central role. Parliament and the Ministry of Health set the rules, while national regulators like the Healthcare Authority and the Healthcare Inspectorate monitor price, quality, and the market behavior. A key feature is the mosaic model, which reflects a moderate level of integration. Instead of the fully central system, responsibilities are shared across insurers, municipalities, care offices, and national agencies. This structure allows different sectors, curative care, long-term care, and the social support, to coordinate without being fully merged. Long-term care is organized separately, with funding flows from the state to regional care offices and municipalities, who manage services like nursing home, home care, and youth care. Public health activities, including prevention and promotion, are coordinated through national bodies such as the INVM.
So in Netherlands, the healthcare is financed through two main pillars. The first one is ZVW, which is the regular healthcare. This one goes for the hospitals, medications, GP visits, and then we have WLZ, which is the long-term healthcare. This one would be like Alzheimer treatment, or nursing retirement homes, or like long-term mental treatment. And for the ZVW, we have three main sources which fund it. So the first one is premium. So as a Dutch citizen, you choose from 40 different insurers, and once you choose, you pay this flat premium rate of approximately €140 every month. Then the employer contribution, which depends on your salary because your employer pays it for you. It is currently around 6.5% of your salary. And lastly, the deductible, which is a average payment of 385 euro every year. Then we have the WLZ pillar, which is funded through three main sources again. Mainly, and the first one is income tax, the second one is government budget, which goes from the general tax, and the third one is co-payment. This co-payment does also depend on your income. Then we have the Kakwan index. So the Kakwan index study whether the system is progressive or regressive. We can see that Netherlands is slightly regressive, 0.05, and it is mostly because of the flat rates and like the flat rate premiums, and the indirect tax still take quite of a big chunk of the financing overall. And we can also say it's partially progressive because of the direct tax. And then lastly, we have the fourth slide for financing health expenditure. So in the left upper part of the slide, we can see health expenditure per capita. So how much average Dutch person spends on healthcare every year. We can see it's approximately $7,000. So for example, significantly less than average American. And we can see that the Dutch healthcare spending was around 113 billion, and around 50% was financed through ZVW insurance, so the short-term one, the long-term one, WLZ, around 25%, and the rest went through out-of-pocket payments, government funding, private insurance, and other things. And so overall, I would like to finish it with saying that one of the main problems Netherlands is currently facing is the financial sustainability because of the aging and increasing long-term care demand.
Now I will explain resource allocation and provider payment in the Netherlands. So for the resource allocation in the Netherlands, healthcare money is divided into two systems. The first one is ZVV, and this covers regular healthcare such as GP visas, hospitals, mental health, medicines, and tests. After money is collected, it goes into a national risk equalization fund, and then it is given to health insurers based on the health needs for their members. Insurers use this money to buy services from providers. And the second system is VLZ, and this is a separate fund for long-term care, including nursing homes and home-based care, and the government allocates VLZ money to care offices and municipalities who then pay long-term care providers. And long-term care is a major spending area because of the population aging. And the provider payment methods, the GPs are paid by capitation and fee for services, which supports access and their gatekeeping role. And the hospitals are paid through the DBC system, which is similar to DRG's. Each diagnosis and treatment pathway is paid as one package, and hospitals negotiate budgets with insurers each year. Long-term care providers are paid through per diem rates and bundled payments depending on care levels and days of care. So overall, the Netherlands uses two funding systems and mixed payment method to support fairness, efficacy, and strong long-term care.
My section looks at service delivery in the Netherlands. The first box is accessibility. Generally, it's strong. Almost everyone is registered with a GP, and hospitals and emergency care are relatively easy to reach. But access is weaker in the mental health side and some community services, where capacity is limited and waiting lists are long. For coverage and financial protection, insurance is compulsory and almost the whole population is covered. Out-of-pocket spending is low by EU standards, and deductibles and co-payments, however, still hit low-income groups harder. In terms of quality, avoidable mortality is low, and primary care, vaccination, screening programs perform generally well. But outcomes are poorer for mental health and frail older people in the long term. In terms of person-centeredness and coordination, most patients do report good experiences and shared decision-making, as GPs generally gatekeep and are the first line for primary care and disease management programs. However, groups with lower education and migration backgrounds report worse communication and fragmented communication between the healthcare system. Overall, Netherlands delivers a high-quality, broadly accessible healthcare, but mental health and long-term services are generally less equitable, and patient experience remains the key pressure points, basically. Thank you.
Now, here are the key recommendations we propose to keep the Dutch health system sustainable. First, we need to strengthen long-term care. This means adjusting eligibility rules to reduce unnecessary admissions and supporting the home care workforce through better retention and training, and scaling up integrated care so older adults can avoid hospital and institutional care. Second, improving the health workforce pipeline is essential. We suggest expanding training capacity, especially in premium and community care, reducing administrative burden competition, and building a national workforce forecasting system that matches staffing needs with the demographic changes. Third, we recommend investing in digital interoperability. Setting data standards and creating regional health information exchanges would help connect GPs, hospitals, long-term care, and municipal services. Providers who adopt interoperable systems could also receive contracting advantages. Lastly, we want to improve purchasing efficiency in the regulated competition model. This includes standardizing contract templates, strengthening risk acquisition to reduce incentives for risk selection, and concentrating specialized services in high-volume centers to avoid duplication. That's all for our poster. Thank you for listening.